All right, so I'm going to talk about dorsal root ganglion stimulation. How many of you have had experience with this, seen it, heard about it? Raise your hands. Okay, excellent. Again, so this is a real fast overview, 15 minutes. We spend 14 hours teaching faculty on this or teaching attendees on this, so to get it in 15 minutes is a little bit fast, but nonetheless, indications right up front. When you see a patient with CRPS, you should be thinking about DRG stimulation right away. Dorsal column stimulation or spinal cord stimulation is pretty good. It's not bad. We have some great outcomes, but there are a number of times where it just doesn't work as well. I have yet to see a patient with sympathetically maintained symptoms not do well with DRG stimulation. Yes, there may be some causalogist situations where they may not meet Budapest criteria and I try DRG and it doesn't work out as well. But if there's fulminant, swelling, color change, it's purple, it just looks like a shiny CRPS extremity, DRG has been quite amazing. And rather than just seeing that 50% threshold, it's sort of the 80 to 100% relief, which is pretty amazing. Causalgia. Causalgia is a term that has gone through a nosological transformation over the last 150 years. So technically, it is a burning sensation associated with a specific nerve. That's where the term came from in the 19th century. With the IASP CRPS committees, which eventually became the Budapest Committee and Criteria, they grabbed that term and used it for CRPS type 2. I think that was a mistake, frankly, because you can have a causalgia without sympathetically maintained symptoms. So that is a situation where you have, for example, a patient has an MCL, knee arthroscopy, the trocar goes right through the infrapatellar branch of the saphenous, they have burning pain right in that distribution. You see them in the office, they don't have a hugely swollen joints, it's not erythematous, it's not cold, it's not hot, but they have burning pain right in the distribution of the nerve. That's a causalgia, but that would not meet the Budapest criteria. So how do you deal with that patient? Well, that's a great DRG candidate if you don't try peripheral nerve blocks first or even consider a lumbar sympathetic blockade. So we can talk a little bit further about diagnoses, but just keep that in mind. Persistent post-surgical pain syndromes, this affects about 10 to 20% of any patient after surgery. So it's a huge deal whether this is after an inguinal hernia repair, after a hip surgery, after ankle surgery, after shoulder repair, thoracotomy, sternotomy, mastectomy. This is a huge deal. This is a good place where I use DRG stimulation, and then peripheral neuropathy from all causes, whether diabetic, idiopathic, chemo-induced, et cetera. The FDA labeling, to be super clear, this is only available to providers who've completed the 14 hours of training, basically from Abbott, because this is probably the most technically complicated procedure that at least I do. Dr. Beal probably does some more complicated stuff than me, but it takes a lot of patience and a lot of understanding of three-dimensional anatomy. It's labeled for T10 down to S2 and was approved in February 2016. The DRGs, as you all know, are the bulbous structures. As you can see back here, let's see if my pointer will work. Laser pointer right here and right here. Notice that there's no VRG, right? There's no ventral root ganglion. The advantage to stimulating the DRG is we're only affecting the afferent or sensory aspect of the nervous system, right? So one of the issues with dorsal column stimulation is, well, what if you fell into the gutter and you started affecting the ventral aspect of the cord? You might see some motor stimulation, right? So those are the patients who say, oh, I feel it in my ribs, I feel it in my flank. You try to stay as dorsal as possible with SCS. With DRG, you're just right on the DRG. It's basically, unless you put the lead all the way across, which you're going to be taught not to do, you're only going to be affecting the sensory aspect. These are from Quinn Hogan, these cryomicrotomes from RAPM. I love these pictures. It really helped me understand epidural anatomy very well. So in the green is the epidural space. As you can see, the epidural space is circumferential on the spinal cord. You should all remember that when you think about any of the procedures you do, but also it peters out as it goes along the DRG. This is what allows us to introduce a needle, the sheath, and the lead into the space. Without this epidural space, we are basically nothing. As interventional pain physicians, we'd have to trust our surgeons to do this. The epidural space was made for us. Most people just ignore it. Like, most of the spine surgeons, it's just in their way. It's just a place for a hematoma to occur. But for us, it's a conduit to a lot of our nerve targets. So I actually love the epidural space, and I don't think we really understand it as well as we should. So really understand this three-dimensional anatomy here in axial cross-section, but then also in sagittal. One of the things I'll look for on my MRIs and T1 sequence is how much epidural fat is there around that nerve roots. So that tells me how much space I have to put that lead. How many of you in this room have done a transforaminal epidural steroid injection? Raise your hand. I should see everybody's hand up, or else you're dead. Okay, so if you've done a transforaminal epidural steroid injection, you probably notice that as you come closer and closer to that pedicle, you feel that resistance and then it will give. Do you guys ever notice that? All right, start to pick up on that. That is not just an osteophyte. That's not just scar tissue. Those are the ligaments that actually surround the nerve root in the neuroforamen. That is what you're puncturing through. And that is what you're going to puncture through as you're coming out with your DRG lead. So you're going to feel that resistance, and then you'll feel a little give, which will be a good feeling. On radiograph, you can see here, these are our targets for the DRGs. As you come down caudally, the DRGs become a little bit more lateral. That's just a natural progression of the anatomy. So our L5 leads should be, our stimulation is going to be a little bit more lateral to the pedicle as compared to, say, L2, L1, and on up. Here's what the equipment looks like. Of course, the 2E is pretty standard. There are two curved sheets. This is the shallow curve. This is the large curve. 95% of what we do is with the large curve. Then we have a stylet within the lead itself. You can't see this picture, it's too tiny. And then you have the lead. The lead itself, if you guys eat pasta, it's like capellini. And spinal cord stimulator leads are like spaghetti. So there's a difference. The SCS leads are a little thicker, okay? The IPGs look fairly similar. It allows for 4 leads. So 4 quattro leads can be used in a DRG stimulator. Patient positioning is super important. I mean, it's always important, but it's like super important for this procedure. If you're off at all, it's going to make your day hell. You're going to spend like 3 or 4 hours doing a DRG when you don't need to. Here is our needle trajectory. So with a lot of the procedures you do, you can get away with kind of just getting into the epidural space. With this, you have to enter the epidural space at a very specific point. So if our goal here is to get to this T12 DRG on the right, what we do is we draw a line from the middle of this pedicle to this point right here in the midline inferior aspect of the epidural space, intralaminar epidural space, and then draw that line out. And then if the patient is 400 pounds, we're starting back here. If they're 80 pounds, we're starting here. So just anywhere along this line, and of course, as we want to enter, if we were to take them in a cross table shot, it would be about a 30-degree angle to the epidural space. And so it has to be perfect, because if we're too longitudinal or coming in too wide, we're going to totally miss our target. Okay, so needle entry is everything here. This is what it looks like for L4 and L5. Again, you see we're just drawing lines out from the pedicle out through that epidural space. This is what it looks like when all put together. So the lead is placed through the curved sheath. Inside the lead is a stylet to give it some rigidity, just like you would do with an SCS. We then enter the epidural space with our 2E. We rotate the curve and the 2E to be married together so that we're actually curving it out towards the pedicle. So there's a lot of steerability with this. And then as we get the sheath out underneath the pedicle, you'll feel that release going through the ligaments, and then we withdraw the sheath while leaving the lead right there. So I like to call us the Uber drivers of DRG. So we are Uber driving the lead to this location, we're dropping it off, and we're leaving it be, okay? So we drop it off, and then what we do is we create tension relief loops within the epidural space. And the reason for that is what mitigates the risk of migration. If you left this lead as you have it here, it will just pull out when the patient bends over or twists. But if we start creating some leads or lead tension relief loops in the epidural space, that lead's not going to go anywhere. And so this is kind of how we do it. We unscrew, we pull everything back, and then this is, by using the sheath, we're able to create that cephalad loop. And we'll show you this in the lab, and we create that caudal loop. So this is what it looks like from stage by stage. 1, 2, 3, there's that caudal loop. And then this is looking at it in lateral. So this is the foramen. And notice the contacts are hollow, so it looks like Cheerios. That's a great sign. That's what we want to see. That means those contacts are coming right out at us. These are some of my own personal pictures, even though they don't show up great on the screen. But here you can see the DRG leads bilateral. This is for a bilateral knee case. This is what it looks like in lateral. Again, we just want to make sure you see those Cheerios. You don't have to make sure you see them, but it's nice to see them. And you want to make sure you don't cross the posterior border of the vertebral body. I also do quite a bit of sacral nerve stimulation, just had bilateral S1s yesterday. This was a case for pelvic pain where she did wonderfully. So we did an S1, S2, and S3 leads. This is what it looks like when we put it into the sacral foramina. And we certainly have growing literature in this field. We do have level 1 with the Accurate trial published in Pain in 2017. And then we've had a number of DRG articles, not RCTs, but case series looking at very specific indications.